We will start. We will start in about 30 seconds. We can see that the participants are entering through what appears to be a very narrow doorway into our virtual webinar hall. Okay. Well, good morning, everyone, or good evening, depending on the part of the world you're joining us from. I'm Brian Golden. I'm the Sandra Rotman Chair of Health Sector Strategy at the Rotman School of Management, and also the Academic Director for the Center for Health Sector Strategy. Thank you for joining us. This webinar is sponsored by the Center. In short, our goal at the Center is for our research, our policy advising, leadership development, and the work of our many graduates, including those of our Global Executive MBA in Healthcare and Life Sciences program, to improve health systems and the performance of the life sciences sector. I'd like to begin today with two acknowledgements. Although this event is taking place virtually, we wish to acknowledge this land on which the University of Toronto operates. For thousands of years, it has been the traditional land of the Huron-Wendat, the Seneca, and most recently, the Mississaugas of the Credit River. Today, while we're meeting virtually, Toronto is still home to many Indigenous people from across Turtle Island, and we are truly grateful to have the opportunity to work on this land. Also, as many of you, we learned yesterday of the passing of a dear friend and colleague, Professor Will Mitchell. I'm sorry if this is coming to you as a shock, as it did to me yesterday morning, but I couldn't imagine beginning today's session without acknowledging Will's massive contribution to our center, the school, his students, and of course the health systems which he tirelessly worked to strengthen. This was truly a tragic loss, and our thoughts are with Will's family. And we want to dedicate this conversation today to Will's memory. He was an incredible friend and an incredible contributor to our system. This panel discussion will be exploring the impact of the global pandemic on the path to greater value in healthcare. And we know many of you have sat through numerous "What did we learn in COVID" webinars over the last year. And having had a discussion, pre-meeting with our panelists last week, I know that this will be a different kind of discussion. The journey towards value-based healthcare and value-based procurement was making progress prior to 2020. Our questions today are: what has happened since then? How has the case changed, both locally and globally? We've got an incredible set of panelists today. Neil Fraser, he's the president of Medtronic Canada and member of the Health Policy Council at the C.D. Howe Institute, and sits on the advisory board for our center. Gabriela Prada, a senior director of Global Health Systems Policy, Global and Government Affairs for Medtronic. And Yves Verboven, joining us from Belgium. He's the founder of EU4 Health Solutions and an advisor to Medtech Europe. We're going to begin with a series of questions. We will encourage you to put your questions in the chat, and I will do my best, aided by my colleague Rosemary Hannum, to sort the questions, and we will stop sharply at 10 o'clock because we know from prior experiences people are booked very tight despite the virtual schedules. So let me begin with Neil. And before we begin with any of the other Q&As, I want to ask Neil to give us a quick primer on value-based healthcare from his perspective, from Medtronic's perspective. So Neil, over to you, please.
Thank you, and our condolences, of course, to the Rotman community for this tremendous loss. of Will Mitchell. He was a great colleague and a tremendous asset to the program and in fact our whole community in Canada. As Brian just outlined, I'm going to try and level set a little bit on what value-based care is. There's some giants, of course, in the industry who I'll refer to. Donald Berwick of IHI, who came forward with first the triple and then the quadruple aim, showing the importance of understanding the patient experience, the outcomes of the patient, the better costs, and the improved clinical experience, for the staff, in fact. And of course, Michael Porter, who in 2006 posited this definition of value, which is the outcomes that matter to patients over the relevant costs, whether they be variable or allocated. And then finally, what is an outcome? There's many different kinds of outcome measures. Of course, we're very familiar with clinical outcomes. There's also functional outcomes, which you can measure with patients. But probably paramount to all of these is the patient satisfaction. Are they able to resume their normal functions and expectations of life? And then finally, operational measures such as length of stay and readmission rates, et cetera. Next slide. Our company has been working with a value-based healthcare framework, which involves 7 steps, which I've sometimes referred to as the 7 steps to heaven. This is a very idealistic, but also very comprehensive approach. And as you see there, it's very important that you're very specific about which patient and which condition, so that you define a cohort. You have to have a very disciplined approach to defining what the baseline is, like before and after intervention. And then very important from an industry perspective is that there's a business model that makes sense financially. Next slide. So just a quick example would be heart failure. So there you've identified actually a very broad patient group, but these are patients who are frequently visiting emergency rooms and frequently rehospitalized. So of course the goal would be to reduce those events, improve the patient satisfaction. And to achieve normalcy, you really stabilize the patient. You probably need 12 months. And then these are just some baseline statistics relating to annual costs and the all-cause hospitalizations per patient year. And so the goal would be to significantly reduce these sequelae. And then ultimately, there would be a role for industry, perhaps, to play an at-risk payment model. It would be even better if there was kind of a gain sharing as well as a penalty for not achieving, so that it really provides incentive to optimize the improvement. Next slide, please. The other thing I wanted to share is that there are various steps that you can take in the direction of value-based healthcare. There's the very simple approach, which we've seen from the pharmaceutical industry, where they have outcomes-based agreements, which we're calling therapy optimization. We've also found the facility to do that in the device industry. And there you see what's called the Tyrex antibiotic impregnated pouch. It prevents infections of implantable devices. And we go at risk for the cost of these pouches to reduce infections. A second step could be really looking at the optimization of the system in terms of the use of resources. For example, in the hospital care pathway, So we've been involved in a number of system optimization projects. This looks more at costs though than outcomes. So you could call it unidimensional. And then moving into, I've differentiated that those first two can be done within existing cost models. But if you are able to create new funding models, such as they've done in Europe and in accountable care organizations in the US, you could have a care episode model that tracks the patient from the hospital to home. There was a great pilot done at Women's College Hospital that demonstrated patients with joint replacements could be better managed. This group won a Canadian College of Health Leaders Award for their program. And then finally, and we're very proud of this, a chronic care management model, which Medtronic has done in Europe called Diabetter, where we focus on a population of type 1 diabetic patients, and we manage their care through clinics and track their outcomes. And we're paid by the insurance industry in Holland for the good management of these patients over time, and essentially getting them inside the guardrails for their blood sugar. Next slide. So as was outlined in Brian and Rosemary's groundbreaking paper in Health Management Policy and Innovation, we have a number of barriers in Canada and globally, such as standardized outcome measures, collecting the data, pre and post intervention and over time. Also, it's extremely important to engage frontline healthcare workers. In this process, you'll never succeed without their endorsement and active participation. In Canada, we also have to deal with the engagement of procurement. And as I indicated, it's great if we can provide incentives to physicians as well as to industry to have some skin in the game. In terms of measuring outcomes, this whole area of PROMs and PREMs, which looks at patient-reported outcomes, which is the best measure of how the patient feels about their outcome. Also, as I'm suggesting, be very, very specific about the disease and cohort, and there's options, as I showed in the ladder, that you can take one step at a time and build a program. Next slide, please. So back to you, Brian. Thank you.
Great. Thanks, Neil, for that wonderful introduction and the overly flattering characterization of our paper. Now, that paper was written about a year ago, and we were reflecting on our early experiences in value-based care across Canada. And it wasn't the most positive story. But our focus today is on what has changed over the last 20 months, whether COVID related or not. So can you share with us your reflections on those learnings over the last 20 months?
Yeah, I think things have continued to move forward in spite of the pandemic. As I outlined, pharma is actively doing outcome-based agreements, as is Medtech. But I think another thing that's occurred, we have a new government in Ontario, well, not that new, but fairly recent, which has implemented the findings of the MP report of May 2017, which recommended the implementation of value-based care in Ontario. And so I've heard recent statements from the CEO of Supply Ontario, which is the procurement agency, as well as Ontario Health, that they are actively pursuing value-based programs. And certainly over the pandemic, we continue to see the data systems advancing everywhere. EHRs are now in place in many of our health systems. Also through procurement, hospitals like Southwood Lake, St. Mary's, the Ontario Plexus Group, the Ontario Mohawk MedBuy Group. Many people have engaged in value-based procurements. And again, I would reference your paper, I think is also a catalyst for deeper thinking about the topic.
Thank you, Neil. We are, for those who've just joined, a somewhat novel approach to a panel. I've asked the panelists to raise their hands if they'd like to add to any comment, as opposed to feeling compelled to add to every comment, or for me, feeling compelled to call on each of them. I'd like to turn it over to Gabriela now. For those who joined a little bit late, Gabriela is the Senior Director of Global Health Systems Policy, Government Affairs at Medtronic. And Gabriela, curious about what you're learning from your experiences with value-based care in other countries. You have a very global perspective, as of course Medtronic does, operating across the globe. But what have you seen that's most interesting to you?
So value-based healthcare, actually, I was looking at the chat and there was one question, is this a possibility to maybe refocus the system into make it really patient-centric? And actually, I believe that the answer is yes to that. One of the things that in COVID-19 is the amount of debt, international debt that COVID-19 has brought. The healthcare spending has grown significantly. So I think that value-based healthcare is increasingly seen as a tool to refocus the system where we need to be focusing on, and also to manage the resources better. So this is something that I'm hearing everywhere. It's something that is certainly very much present in the Asia Pacific area. I just had a conversation in Latin America 2 or 3 weeks ago, and it's very high on their agenda. So I think that from a value-based healthcare perspective, there is that understanding, recognition that this is the time to start using some of these tools. Talking about the procurement side that Neil mentioned, and I think the procurement side is very important in countries like Canada. So when you have national health systems that rely on public procurement to bring healthcare technologies and services into the healthcare system, if we don't align the procurement frameworks with value, it's very difficult to really implement value-based healthcare, frameworks overall. So I think the bringing the procurement aspect into the value is certainly quite important. And one of the things that is evident to me is that value-based procurement is starting to be seen as an instrument to transform healthcare. So it's kind of an enabling transformation. And the countries that are seeing this procurement transformation as a big change management exercise are able to do the management a little bit better. So, like any change management, you have to engage with stakeholders, communicate, create a vision, mobilize for action. All of these elements are really important in making sure that value-based procurement continues to grow and flourish. And it has continued to grow. I was looking at some of the statistics, and certainly in Canada, Neil mentioned that there is some more value-based procurement projects. From my perspective, not only we have more, I think they are also better. The quality and sophistication and maturity of those projects is significantly better than 10 years ago. So I think we have made tremendous progress. The other thing about, and this will be my last point, there are two other things. One is that in terms of value-based healthcare, it's a very strong movement towards green procurement, particularly in Europe, and that's something that certainly I see that coming to Canada very soon. And what does this mean? It's a commitment to the healthcare sector has to contribute to environmental sustainability. So the NHS, for example, made a commitment that by 2045, they will be carbon neutral. And what is the implication of this? Well, that in every tender, they are now asking how you are contributing to our environmental sustainability. So that has become part of the tenders. And my last point, very much related to COVID-19 and tenders, I think that this notion of value has become broader in a sense that now we are starting to look at social solidarity, equity, equality, and how we can incorporate some of these principles into the value aspects of of healthcare, health services and solutions. So that, again, everything that we've been through with vaccines globally is resonating. And I think that experience is going to leave a mark in healthcare.
Great. Thank you for that. And I think it's wonderful that sustainability is now part of how we think about value for a health system. Let's continue with our global theme and go to Yves in Belgium. And Yves, what themes do you observe from your experience globally around value-based procurement in the European medtech industry?
And thanks for the opportunity to also contribute indeed to the session. And of course, I'd like to echo what previously was said with regards to how the concept of value is increasingly taken forward, and also the notion that it is important to look at ultimately what is being valued in the offering, and how it links to the also societal values, which is something that we're bringing in also within the health systems that we're having here in Europe. And just to take one step back in the framework that we're having within Europe is that in 2014 we got actually a new procurement directive, which put forward actually the focus on realizing economically most advantageous tendering. And they're aiming to do this by applying actually a combination of quality aspects, as well as then looking at the price, and so getting into a best price quality ratio. And this is something which is then very closely connected to the thinking of making sure that we get good outcomes, and also on the other hand to see how we apply it into the cost of care delivery. So what we have been doing is actually translating this best price quality ratio into a value-based procurement approach, and looking there at a quite comprehensive way when talking about value. So at the core, we're of course putting also what really matters to the patients, but then also we're looking at the whole healthcare system, so the healthcare actors. So what actually means it for the different healthcare actors of the solutions which are brought into the system. And we put an outer layer, which is more going then beyond that. So looking at the policy side, look at the societal side. And in there, we bring in, for example, the environmental aspects, but other socioeconomic aspects as well. So we're really trying to build up and looking comprehensively of what is it that people appreciate and for which they're ultimately willing to pay for, and seeing then in this way to actually bring the different innovations into the system. A couple of examples there. In Wales, what people have been looking at in driving also towards value-based healthcare is to see how they can optimize anticoagulation management. And so what they identified is at a situation where they were very dispersed in the way that they actually were providing this. A lot of patients went to the emergency room, others went into GP, others tried to do some self-care. And so they actually said, okay, let's somewhat get this streamlined and let's apply within the procurement a way to identify a point of care testing together with then an appropriate management. And this is something that they introduced by means of an innovation procurement, applying then a value-based approach. So one is on the streamlining of care provisions. The other is within the hospital setting, trying to optimize somewhat the care provision there. Example there in France, we're looking at hypothermia management, where they noticed a lot of post-surgery still incidences of going into intensive care, complications. So certainly from the clinician side and from the nurses side, it's very unsatisfactory of what actually the post operational care was giving. And so it did not resolve in just buying some warming blankets, but really looking at then solutions in order to really address the management. And I think that's a key word. More and more people are looking at the management of the care. Other example, more looking at healthcare resources. For example, in the Netherlands, they were building a new hospital. Within the setup, they had the doors without windows. So it's a silly example there that they forgot this. But then they said, okay, what's the solution in order to avoid that nurses have to run around through the night in order to just see if patients are still in their bed or had falls out of the bed. And so I actually said, okay, let's bring a solution of innovative and smart beds in order to monitor, reducing the healthcare resources, upgrading the quality of the nurses, of what work they had to do, and in that way also optimizing the patient care. So a lot of those more solution-oriented offerings, quite practically, which we have been implemented, but also looking just at bringing products. So if you look at the bringing of syringes, there people are looking at what actually the view is from the patients and from the nurses. On gloves, looking at the allergic effects. So really being inspired by those different concepts, we see increasingly the utilization of value-based procurement within Europe. And in this way, the way forward to combine some of the quality aspects and then also getting economically the best results.
Great, Yves. So keep your microphone on, and I'm going to go a little bit off script to our panelists. But one question came in, and I'll elaborate a bit more. We know this is really hard to do because the measurement of outcomes can be very difficult, particularly because we have to specify a time frame. And the real benefits may accrue later than we would typically measure in a clinical setting. So let me start with you and then maybe turn it over to Neil on this question, and that is, how well do health systems measure outcomes associated with med? Is it during the procurement process a nice to have, or is it becoming a requirement?
Yeah, I think it's an excellent question, and I think what a lot of challenges that people and systems have been facing is to try to get all infrastructure up in order to get this measurement being done. An alternative way, what we actually see in the setting of the value-based procurement is actually to address this twofold. One is actually at the request of a solution to make this part of it. So in the example in Wales, they were not only looking at point of care testing, but also asking how the suppliers could ensure this measurement of the outcomes and what type of software provisions they would actually do and take the accountability of doing these type of measures. So in this way, similar in other cases where the demand is then given also to the supplier to see how they can support in this direction. And second, towards then the industry is to build up a type of value-based agreements where the aim is then to look at, okay, based upon those measurements, can incentives be given, or if these are not reached, what type of further partnership can be built up in order to innovate this, in order to get this actually established and improved. So I think those are the mechanisms, not to actually seek for getting the whole system and for infrastructure in place before and then doing the measurement, but make it part actually of the solutions which are offered, and in that way making sure that these measurements can take place and some incentives can be linked to that. So that's the way that people have been looking at it practically.
Great, thanks, Yves. And Neil, what would you add to that from a Canadian perspective, or anything you've seen in your global travels, virtual global travels recently?
Yeah, I would say that that currently the measurement of outcomes is inadequate for patients that are not in clinical studies, but there is new technology available which integrates remote patient management capabilities and measurements at home, as well as things like patient-reported outcomes. And we're seeing the recent ICHOM meeting reported a number of new platforms that are very much focused on collecting this data. But I would say in Canada, we're primarily measuring discharge data, and we're not following the patient through their course of recovery. And that's where a lot of key expenses occur, complications, reasons for the patient to come back to emergency, even go back into the operating room. So it's really, I think it's something, perhaps you were bringing up the flavor of the pandemic. The pandemic has shown, patients' overwhelming interest and willingness to use virtual care. So they're ready and willing. And what's missing is, the framework for reimbursing the collection of this kind of data. And it has a very good ROI, by the way. It's a very good investment, but it's not in place currently. And I think that's an opportunity for Canada to implement that.
So it seems to me it's also a real opportunity for a Medtronic competitive advantage with your scale and your 10-year journey working around value-based care to share your experiences to develop those more sophisticated measures. So that's fascinating. Gabriela, thank you for following the professor's instructions and raising your hand. It's all yours.
You're welcome. I can be trained. No, I totally agree with Yves and Neil. And I think that, in measuring outcomes is complex, right? Because as Neil pointed out, it doesn't depend on a hospital, it doesn't depend on a region alone. There are components of data that are, within a health system, within the hospital, in patient hands, within the vendors. So it's integrating all of these to make sense and extract some intelligence of all the numbers and key performance indicators. This is where the real value is. And I think that as procurement moves from transactions, if we put a very, detailed technical specification to buy something that is fragmented, that is not really linked to the strategy, and do that, in isolation, the capacity to measure outcome for this is very limited. But as we see procurement that move into partnerships, where we are sharing the risks and the benefits, then there is a mutual need to measure these outcomes. And this is where the outcome, the capacity to capture what matters and to develop these data sets and to bring some intelligence really goes up exponentially. It is in the best interest of everybody who is involved in value-based healthcare to measure outcomes better, because we cannot scale up value-based healthcare without evidence. And actually, the diabetes example is a good one. Neil mentioned that this is a clinic in the Netherlands. Yes, it was born in the Netherlands. We actually had an agreement with the government of Saudi Arabia to test one clinic. And it was very intense 2 or 3 years of collecting data, demonstrating the real value for patients and for the healthcare system in Saudi Arabia. And now we are at the moment that the government said, we want this care for the entire country. Everybody should have access to this. So we are looking at, dozens of clinics and have national coverage. The only opportunity to really scale up these models is by collecting data. That's the only way.
Thanks for that. And Yves, I see your hand. I'll come back to you in a moment. One of the potential advantages, and I'm curious, Neil, if you could first comment on this and maybe open it up to others, is, in a sense, no one has more confidence in Medtronic's products than Medtronic. You've got more historical data, you're closer to the product. And even when procurement contracts do not require outcome measurement, are you more comfortable in putting that as part of your procurement agreements because you are confident in the historical experiences of your products?
That's a great question. And as our former global CEO used to say, as a company, we're ready to sell outcomes versus products. And you're right. We have very strong clinical data on all the products that we sell. And so we're comfortable predicting, what the outcomes will be. So I think, and I think that's true of a lot of our industry. Yeah, absolutely. I think that's the direction that things have to go. is we have to focus on the healthcare system should buy outcomes, and it should be incumbent on us to deliver the outcomes and also to measure and prove to them that that's been achieved.
So that's a wonderful insight, because we know health systems tend to be more risk averse than less risk averse. So seeing the private sector come and say, we've got the confidence to commit to these outcomes is absolutely wonderful. Yves, apologies for skipping over you there, but please, let me bring it back.
No, absolutely not. And I just wanted to add, and what Neil also indicated, I mean, this is clearly the direction of travel. I think what's important is to see how stepwise to get to this point, and not making it an upfront requirement that all systems need to be in place in order to be able to go there. So I think it's really in partnership that things need to be built up and built out. And also with regards to the financing mechanisms, it will be important not to be fully dependent on just the outcomes, because then a lot of discussions take up. So again, it's important to see it in a positive dynamic of how potentially by reaching those further incentives can be given. And just to indicate that even without having already the infrastructure in place, it is possible to really already take a value-based approach forward with a patient centricity putting forward, and have them involved into the appreciation of what's being offered.
Great, thanks for that. And my panel knows I've completely gone off script because the questions are so wonderful coming in. There was one question, and I'll come to you, Neil, and maybe you can incorporate your answer to this. The question of really whose responsibility is it to develop system level outcomes? And some of the examples are government, industry, clinicians, and researchers. And I think the answer will be all collectively. And then do different outcome requirements vary by different systems? And I think, of course, yes, again. But Neil, your hand is up. Let me turn it over to you.
Yeah, well, it's interesting that I was thinking in the same direction as you. And one of the groups that I mentioned briefly earlier is ICHOM. And if people aren't familiar, it's the International Consortium for Health Outcomes Measurement. And this is a group that's pulling together, standardized outcomes, working with the best medical databases and societies. At last count, they were north of 50% of human conditions and illnesses, be they chronic or acute episodes. So they have standardized data that you can use to baseline. And yes, it is true that outcomes will vary by health system, but I would suggest that if they do, that points to an issue with that health system. Because, if you have a condition anywhere in the world, it's the same, it's the same condition if you've selected the cohort in an equivalent way. And so therefore you should expect the same outcome or better. And so I don't think it's an excuse to say, well, our system doesn't deliver the same outcomes as the Swedish system or something like that.
Thanks, Neil. And one question that is on our list for today, and particularly relevant to COVID, we've never heard so much about supply chain as we have in the last 2 years. And supply chain has never been so sexy and so exciting. So Yves, I'm going to turn it over to you, at least to start, for your reflections on the interaction of value-based care and supply chain over the last 20 or so months.
Yeah. And it's indeed a point which came to a major attention because it did somewhat bring back the question with regards to supply chain, with regards to procurement, going back to the basics, which is to secure actually the ability that products were actually available. And there, what we did see is that increasingly people started to value the ability to actually have products and to have a working supply chain. And what we noticed in Europe was that it has been a very, very chaotic type of approach, where you had completely uncoordinated type of demands coming from local hospitals, regions, group purchasing organizations, national member states. The EU stepped in to try to combine it, but then put frameworks in place where nobody committed to actually then the buying. So it was clearly the completely, let's say, uncoordinated type of approach. The ones that actually fared best were actually those that had longer standing relationships with the suppliers, where there was a lot more partnership types of built up. Those that have had built up some good sourcing systems in order to identify reliable type of suppliers. And so the term of resilience has come forward in Europe, where actually in the improvement for the whole health union, this is now a key topic. So how to ensure to make actually the health systems much more resilient, the supply chain much more resilient. At European level, initiatives are taken in order to build out actually potentials to relocate the supply and the production more within Europe. Procurement organizations are actually building up their own ability to actually self-produce, and in that way to ensure the products. So this aspect of resilience has been increasingly valued and starting to be considered as a key element within the procurement aspects. But also going beyond that, not only the products, but also the resilience of being able to provide the healthcare also in non-COVID related diseases. So how are you, for example, providing dialysis? Do you have to do it at hospital, or are you transferring it actually into more home care? And those types of the resilience of healthcare provision is increasingly being part also of then the procurement requests that are being put forward.
Great, thank you for that. And I think it's impossible to think about resilience across the globe in our health systems without also thinking about health human resources. And Neil, we had a really interesting discussion last week about health human resources and the value agenda. Could you speak to some of your observations and insights there?
Yeah, well, I probably don't have to tell anyone that you know, we've experienced you know, broadly a health human resource crisis that it's amounted to, and this is not just true in Canada, it's true in the US and Western Europe. About 1 in 5 health worker positions is vacant and not likely to be filled anytime soon. And as a result of that, you know, you know, health human resources become a scarce resource, and it's not even about the cost anymore, but certainly it's not free anymore. And what we've seen as an industry is this has created a very welcome greater appetite for technology solutions that could potentially you know, reduce the need for FTEs and also to cross budgetary silos in healthcare, whether between the hospital and the community, or even, as we've discussed before, even within hospitals, there's tremendous silos. And you know, a good example has been the growth in virtual care, you know, but also you know, dealing with the large backlogs that are current and continuing to grow. Things like minimally invasive approaches to surgery, you know, other things that get patients in and out of care settings more rapidly.
Well, thanks, Neil, and stick with us because it was an earlier question about the importance, particularly during COVID, of the integration of the hospital, primary care, and community care integration. And if you could speak to either your observations of successes or real needs and innovation around how value-based care can incorporate that collective and that integration across the system and the full value chain.
Yeah, well, I think that, we've seen, there was a lot of learning from accountable care organizations in the US. And I know here in Ontario, there's Ontario Health Teams, which are still at a very early and underdeveloped stage. But I also referenced in Europe, the development of specialized clinics that primary care can feed into for specific conditions, whether it's different diabetic conditions or heart failure or obesity and these kinds of things. And so it allows you to, track the patient from the time of presentation right through to, recovery or return to a normal, acceptable state to the patient. And I think, so it's about integration of care, but it's also, getting back to the earlier discussion about the need to really track the data for the patient is so critical. So all of these things I think are coming into very sharp focus as a tremendous opportunity. And somebody commented earlier about the the whole patient going beyond just the healthcare measures, like what's the phrase I'm trying to think of that incorporates the patient's home and education and nutrition and
the social determinants.
Yes, there you go. I'm sorry, I'm just drawing a blank. The social determinants really also comes into play when you start to do this.
Thanks. And Gabriela, you are our policy guru on the panel, and curious about your observations of how we can improve value from both a policy and an organizational perspective. Where do you spend most of your time thinking about policy issues?
So, I following Neil's comment, I think that keeping in mind the importance of the social determinants of health is really critical. I mean, we need to go from seeing a patient in a transactional way to actually looking at the patient across an integrated pathway. And the more integration we see along the different care modes that we have and the longer term perspective that we take of success, I think the better it is. So from a policy perspective, everything that we can do to create incentive for that integration to happen is going to pay off. And that is, what type of incentive we have in place in terms of payment mechanisms. Are we paying for teams? Are we paying for episodes of care, or are we paying for the integrated care? What type of incentive we have for different professionals to work together? What are the modes of care, the models, integrated models that we are encouraging? So I think these are the things that from a policy perspective have proven to make a big difference. And we have good experiences in Ontario. Ontario has been working towards a funding transformation for, I would say, 2 decades, looking at different primary care models, experimenting with quality-based procedures, experimenting with different funding mechanisms for hospitals to achieve certain targets for diseases. Now we have the Ontario Health Teams that has more integrated aspects. So I'm not suggesting that we haven't done anything, but I think the more we can do to make sure that we don't go off course, I think is going to help us. I also think that there is another aspect of this, and I think from a public sector perspective, this is important to keep in mind. One of the things that we have discussed in international tables that have been a barrier for change is the lack of appropriate commercial mindset within the public sector. And I think, what do I mean by that? I mean that it's important for public sector to understand how they create value, how they measure value, how value could be pushed and boosted. And I think the lack of understanding of the interrelation with resources the resources they have with the suppliers, partnerships, all of these from a business perspective has been an issue. I think to the extent that we can fine tune some of those skills, I think the possibilities to engage into more meaningful conversations to create value with the private sector and also put the expectations right in the place, from the beginning. I think that will go a long way.
Great, thanks for that, Gabriela. And I just want to emphasize a word that too often gets lost in this discussion around incentives or rewards. I've been sounding like a broken record for a decade, but it's not just about measurement. Before we get to the outcomes we want, we need to ensure that our incentives and rewards are at least not moving us in the wrong direction, or at least supportive of what we say we want to achieve. And that's tough. But that integration of professionals and organizations and the private sector coming together around aligned incentives for better outcomes is absolutely critical. What I love about our audience questions is so many times they're really statements and not questions. There is one: can our focus on value-based care focus on patients rather than providers? I take that as a rhetorical question and a wonderful observation that we don't do a particularly good job of it, in many cases. So thank you for that observation. Gabriela, while your mic is still on, I know you've had some very interesting experiences in Denmark and the UK, and we're always looking to learn from other settings, whether success or failure. So can you share with us some of those experiences?
Yeah, sure. I mean, so Denmark is a good example. In Denmark, they had the whole framework for innovation and value-based healthcare, and they put procurement really in the center. And what this means is that there is a really strong understanding of what value-based procurement or what innovation procurement can do for them. So I think that everybody within the healthcare system understands the potential. They had also invested some time and effort in developing some tools to help them to do this job, how to measure value. And they've been working for some time. They worked for some time on developing this, the Copenhagen model, which I think is great. It looks at, how any initiative can increase productivity, decrease the consumption of other healthcare services, and increase the patient outcomes. So this type of broad view, systemic view of value, I think is really helpful. France, for example, I love how France has started thinking about value-based procurement as a quality improvement mechanism. So now they are trying to use these and align the key performance indicators to make sure that this is very much in line with some improvements within the healthcare system. I think that systemic view of value is important. It really conveys that there is a good understanding of what the possibilities are and also how to get there. And I think, if I reflect on Ontario, from an Ontario perspective, we have spent a lot of time thinking about this. And I remember when I was part of the expert panel, supply chain transformation for Ontario, one of the things that we said, value has to be very, very present within supply chain in healthcare in order for us to pursue value from different corners and make sure that as a system, the province will be better off. And so I think that systemic view is quite important, and I really hope that the Ontario government will continue going into that pathway. Not to say that other provinces are not doing it. I think that from a policy perspective, probably we have the richest experience in Ontario, but there are other provinces that are smaller and maybe not as loud, but doing really interesting things. So I always look at Atlantic Canada. They are doing really interesting, experiments. I love the energy in Newfoundland. They are creating a really good ecosystem for transformation. So this is great. and New Brunswick, for example, other great examples too. So yeah, I think we can learn from the international experience, but I also think that we can also learn a lot from what's happening within Canada too.
Okay, thank you. And so we're heading into our last 5 minutes. So let me go to Yves and then wrap up with Neil. Yves, what advice would you give for countries wanting to improve value or at least become more value focused?
Yeah. So I think it's important actually for countries to be aware that at this moment, they still have like a 20% inefficiencies in their health systems. So there is a tremendous financial resource which can be tapped into in order to address some of the challenges of pressures that they actually are facing, which are more the expenditure type of pressure. So I think it's important. And we see a lot of people also then looking into a value-based if this is going to help them in order to solve this question. And I think it certainly can, combined that they can at the same moment also ensure to get then the outcomes improved for their patients to address some unjustifiable variation that there is in the outcomes, but also the issues with actually the healthcare delivery and safe healthcare delivery. There is a tremendous amount of complications, of issues associated with it, which can be addressed, and again, which can contribute to the system outcome to really have a more performant type of systems. So I think that having this ability and also the awareness, and that's an interesting study, which was an eye-opener for me, that what you actually need is 0.5% of efficiency gain per year in order to overcome your pressures on your system. And if you address that together with them focusing on a better outcome, more consistent outcome, you can get a very sustainable type of systems in place. And I think people need to get continuously being inspired by this, how to incorporate value into the investment decisions, and really seeing how this link can be made and by what is this going to be guided. I think looking at the economic value together with the outcomes might be important. When I talk about economic value, I'm looking at efficiencies in the system. I'm looking at the prevention and avoidance of cost by having people in good health, and also actually the economy of being actually in a good health and the contribution that a healthy person can provide.
Great.
And
So
to finish up, I think the final point, what I would advise is really to start partnering with the medtech industry. There is a lot of opportunities and commitments, and this moving away from the industry as being a supplier of products to really a partner in getting solutions to the problems. I think that would be really a major step forward.
Great, thank you. And Neil, last words before I try to wrap it up, and that is around, what are you most optimistic about?
I think what we've seen in the lessons of the pandemic is that patients have really been leading change. And as they are voters, I think that's influencing the stewards of the health system, and also very innovative physicians and healthcare workers. Technology continues to advance, whether it's telehealth or, we talked about EHRs, remote patient management. And in surgery, a very exciting new development is robot-assisted surgery, which can improve productivity in the operating theater and improve outcomes. So technology moves forward, and I think there's a greater appetite with this crisis for all of these things to advance. So I'm very optimistic for the future. And I would say to Yves, in industry, we think of improving productivity by 50% every 5 years. So, 0.5% a year, I think, is very modest. And I think that's the kind of challenge that healthcare needs, is to look at their productivity.
Great. Neil, thank you for that. And as we wrap up, I want to make a plug for Neil's podcast, The Next 100. Fascinating discussions with our health system leaders. And that I don't continue to contribute to the health human resource gap. We are going to end right at 10 o'clock right now, our time. Thank you, everyone. Let me thank our panel, Neil Fraser, Gabriela Prada, and Yves Verboven, for joining us. Fascinating discussion, and it's just the start, or at least maybe the midway. Everyone, be well, happy holidays, and we'll look forward to seeing you after the new year. Thanks, everyone.
Thank you.
Thank you. Bye-bye, everyone.